Hey, everybody, it is Kathy, and I want to welcome you to this April, to this HIE Awareness Month, and to this series of read broadcasts that we've done to celebrate and to honor and to bring awareness to HIE and all of the work that's being done, some of the controversies that still exist, and some of the opportunities that we can give ourselves in our units. In 2022, we did a series of videos, and we called the series Caring During Cooling. We had speakers on mild HIE, on holding during cooling, on ventilating during cooling, and feeding during cooling. We also brought back some of our favorite presentations we also had family advocates like Betsy Pylone from Hope for HIE sharing with us about the parent perspectives on mild HIE and what's coming next for that. So on our YouTube channel in April, we are going to be sharing all of this with you again. And we're going to be using YouTube because we'll be able to do live broadcasting and live Q&A and just create some conversation around these very important topics. These are all opportunities for us to do better for these babies. So thank you for being here with us. And without further ado, we will dive into our presentation. So in this presentation, I'm excited to bring to you a replay from Celia Glennon, who is a nurse practitioner from Lucille Packard Children's Hospital at Stanford. She's going to be sharing her research and her results from her holding during cooling program. So I hope you enjoy this Encore presentation. We'll just dive right in and we'll continue this caring during cooling conversation through the year and making sure that we can share the information as it's coming out and to collaborate on these ways that we can continue to improve outcomes for these babies with HIE beyond just providing the right temperature management, which I know Celia spends much of her days and time doing that. So again, it's my pleasure to have Celia with us. I called her on a whim when I had received 3 emails in one day that was, what do you do about holding during cooling? And I said, Celia, we have to do this talk and we need you to share your data and the process of what you've done at Stanford to make cooling better for babies, for families. And so I could go on and on about her, but she really leads out in our neuro NICU and really guides the way for our new staff and for new fellows and new attendings and new residents and new nurse educators. She constantly is teaching, and her passion really over the last decade has become cooling. And Celia, I'll let you take it away, and thank you again for being with us today.
Thank you for that very warm and heartfelt introduction. I really, truly am honored that Kathy asked me to present the work that I've been so passionate about for years and years. And it's just exciting for me to be able to share it with you. And I put my email address on my first slide, hoping that you guys will jot it down in case you have specific questions afterward, and just send me a message after the talk. To start, I can't believe it's April, it's HIE Awareness Month. And very timely for me to present our holding algorithm at LPCH, that's Lucille Packard Children's Hospital at Stanford, and the project that I've been working on for almost 5 years, holding during therapeutic hypothermia. And I am so glad to see so many of you here joining and sharing my interest in brain care. So I'll get started now. My first slide here, I borrowed the right half of the slide from a colleague at Stanford who I have great admiration for, Dr. Sonia Bonifacio. She recently gave a presentation last week, a Vaughan presentation called All Care is Brain Care. And I just loved the slide about neuroprotective care because this is the heart of what we're going to be talking about today. When we talk about neuroprotection or neurodevelopmental care, it's synonymous with neurosupportive care. And what we really mean is brain-focused care. And we try to have in our neuro NICU at Stanford a focus on caring for the brain, and even with patients that don't have brain injury, because all patients have brains and all patients need brain care. And recognizing that much of what we do as healthcare providers is not neuroprotective and potentially harmful over time. Just think about all those heel sticks that babies endure and other painful procedures they endure while they're in the NICU. With that in mind, our goal is to approach each care interaction with a neuroprotective lens. where we can balance the benefit and harm of what we do at the bedside. And holding is a perfect opportunity for us to do just that. The slide on the right is a good visual to show that there are many aspects to neuroprotective care. Today, we're going to focus on positioning and handling, or holding. Despite proven benefits of parents holding their sick newborns, it's been challenging to implement this practice in our NICU at Stanford. For example, in 2015, none of our HIE patients were held during cooling, and less than 5% of extremely low birth weight infants were held during the first week of life. We hypothesized that common rationales for not holding sick infants included safety concerns, varied skill levels, and a lack of standardized practice. In order to better understand staff decisions around holding, one of my NP colleagues, who also shared a passion for increasing parent holding rates, she and I created an online survey aimed at identifying the barriers to holding. This started in 2014 when I was working on our brain care bundle as part of the Vaughan Micro Preemie project. And what we determined was that there was a real lack of consistency between providers and how they felt about endorsing holding. The holding rates, when I did the chart audit for all of our extremely low birth weight infants, were less than 5% during the first week of life. And as part of the Vaughan Micro Preemie project, our goal was to have all infants held during the first week of life. Using a neuroprotective lens, we want to view every patient interaction as an opportunity to be brain focused and to impact the microstructure and function of the developing brain. I mentioned the brain care bundle. We started working on this in 2014. This was an update which only included 3 patients. But as you can see, our goals in the Micro Preemie project were included midline head positioning in the first 3 days of life. And our goal was to have above 80% in all of these areas, and which we did. We had 100% of midline head positioning. We also placed NIRS for the first week of life and had 94% of our patients. This was done. But where we fell short was where patients were held during the first week of life. And you can see 33% was the number that we came out with in the beginning of our project. But this only included 3 patients. As I said before, when I went back and did the chart audit for all of the patients, the number was actually less than 5%. And of the 5%, the less than 5% that were held, they were all held during transition to comfort care. So this was an awakening for me that we really needed to get to the bottom of why these babies are not being held. So as I mentioned, we put together a survey to get a better understanding of what was going on in our NICU. What was our NICU culture? We distributed an online survey, and the response rate was 30%. While we sent out over 300 surveys, 93 participants responded. 59% of the responses came from bedside nurses. 26% came from medical providers, either physicians or nurse practitioners, and 9% were respiratory therapists. And of the survey responders, 92% had positive feelings about facilitating holding. However, only 48% felt confident safely transferring the infant from the bed to the parent. And 62% indicated that a holding algorithm would be helpful to their practice. 76% felt that they'd be more likely to endorse this practice if they knew there was a neurologic or developmental benefit to parents holding their sick infants. I'm going to run through the questions from our survey just to show you what we identified in our NICU. If you are having challenges getting your patients held during cooling, you may also want to put together a survey to get a better glimpse of what the dynamics are at your particular unit.
Could I interrupt you really quick? There was a question as you dive into this. I think it might help people. They were asking, how do you define in your survey or in the practice when you looked at the data being held? Was it only skin to skin, or was it any kind of holding, even swaddled blanket holding?
So that's a very good question. This survey was designed for all infants in the NICU. So it was skin to skin and holding, not skin to skin.
Perfect. Thank you.
Yeah. We asked, what devices do you currently use to secure patient lines and tubing for holding? And got a wide variety of responses. 58% said they used some sort of tape and posies. Other devices that were used, that were listed, were hemostat, Kelly clamps. Some people used pillows, safety pins, forceps, and other types of clamping devices. We in the Neuro NICU got to trial the Neotex Velcro strap and had a lot of success with that. So I put a picture of it. I'm not sure if you all are familiar with it, but they come in blue and pink and blue, and this is a Velcro strap with a clip. So you can actually put the IV tubing inside the Velcro, seal it, and then clip this to a blanket or to prevent it from pulling and IVs from becoming dislodged. But as you can see, there were so many different devices being used. It really was just a matter of individual preference for how it was getting done. I also asked, on a scale of 1 to 5, how much does NICU bed space significantly limit your ability to facilitate holding of infants? And at the time we submitted this, we did this survey in our NICU, we had 50% of the bed space that we have right now. We've grown quite a bit at Stanford because we actually have taken over our former CVICU, and now we have double the space. But at the time the survey was obtained, 62% said that space was an issue frequently or all the time. So it was a real barrier to getting babies held. We also asked, does NICU staffing significantly limit your ability to facilitate holding during your shift? So do you have enough hands available to safely move the baby from the isolette or the radiant warmer table to the parent? And in our unit, about half the staff believed that staffing was okay, and another third said that staffing was not adequate. So that was a barrier to holding. Another 19% weren't sure. If I knew there was evidence of a neurologic or a developmental benefit for holding fragile, sick newborns, I'd be more likely to endorse this practice. So in our unit, granted this was 5 years ago, 76% said that if they knew there was evidence of neurologic or developmental benefit for holding, that they'd be more likely to endorse this practice. So this was an opportunity that I saw and my colleagues saw as, we can educate our nurses, we can educate the providers at the bedside, and hopefully impact their decisions for holding in the future. I am reluctant about infants being held during therapeutic cooling for HIE because I fear patients may drift out of range from target temperature. That means below 33 degrees or above 34 degrees. This answer really surprised me because 46% of our respondents were concerned about patients drifting out of range while being cooled. I was surprised because we use an esophageal probe to internally measure the infant's temperature, and the temperature of the blanket is controlled by the baby's temperature. So if the baby were to warm up or to cool down, the blanket will adjust to maintain a constant temperature. 27% weren't sure about drift of temperature, and 27% also were not concerned. I took this opportunity to educate staff about the dynamics, the functions of what we were using, the Blanketrol, and we now use the critical machine, but it has the same operating mode where it's controlled by the patient's temperature and it's auto-regulated. Educating our staff was another tactic we used to hopefully improve our holding rates. We also asked, would having an algorithm to determine readiness or safety for holding improve your practice? And 62% said yes. This was, again, helpful information for where we needed to put our efforts. And sick neonates are often attached to medical equipment involving lines and tubes. And we asked, in your opinion, which instances do the risk of holding outweigh the benefit? And both of these columns on the right and on the left have the same information in just different formats. But what the response rate showed us was that an overwhelming majority of people across all disciplines identified patients that were intubated on high frequency ventilation and patients with chest tubes. The majority of staff felt that these patients, the risks outweighed the benefits for holding. I should point out that in our NICU, when patients are on high frequency oscillatory ventilation, we use stiff tubing. And I know that there is some flexible tubing that other units use and have had success rates with holding. Because of the stiff tubing that we use in our unit, it just isn't felt to be safe. Other areas, as I mentioned before, the cooling blanket, 45% identified that as a risk that would outweigh a benefit of holding. And equally, babies on inotropic support. Almost half the respondents felt like these are patients that were just too unstable for holding. We developed, as a result of the survey, we formed a multidisciplinary holding task force to develop a holding algorithm with guidelines for safely transferring infants to and from parents. And this is the algorithm that we developed with input from the survey and then the multidisciplinary task force. And we divided the babies into 4 categories. The sickest babies were called extremely ill and or unstable. And these were patients that were on ECMO or pre-ECMO, on high frequency oscillatory ventilation, had poorly controlled hypotension, were paralyzed, or were defined as having a critical airway by our ear, nose, and throat specialists. These are patients right off the bat that we recommend defer holding, but allowed exceptions could be made by the neonatologist's own discretion, but that in general practice, we felt like these patients should not be held. But we recommend developmental interventions aside from holding, developmental positioning, teaching parents on positive touch and appropriate interactions, titrating pain and sedation meds to effect. And we strongly consider a developmental team OT, PT consultations in these patients that are too sick to be held. And the next category is critically ill and labile. And these are patients that we defined as having chest tubes, being on inhaled nitric oxide for pulmonary hypertension, babies who had stable blood pressures on inotropic support, post-op patients that might have some pain issues, and infants that have poorly controlled pain. We recommend discussing these patients with the medical team and for input whether yes or no these patients should be held. And if the team recommends not holding, again, we recommend these developmental interventions that I've already outlined. And if the medical team feels it's safe to proceed with holding, then we move over to the NICU holding guidelines, which I'll get into in just a moment. I should point out that extremely ill and unstable and critically ill and labile patients do not make up the vast majority of patients in our NICU. Most of our patients fall into the critically ill and stable definition, which is infants on conventional ventilation, infants with umbilical lines, arterial or central lines, infants on drip medications like morphine or aminophylline, and infants undergoing cooling on the hypothermia blanket. Also, on our 4th column is clinically stable infants. These are infants on CPAP, high flow nasal cannula or room air, infants on G or amplitude integrated G or NIRS, a near infrared spectroscopy monitoring, infants with central lines, PICCs, replogals, Foley catheters. These are babies that are clinically stable and there's no contraindication to holding. So we recommend proceeding to our holding guidelines. And I have the Appendix A for securing airway, Appendix B for securing lines and tubes, and Appendix C for cooling patients on the next slides. These are the ones that are going to be a little hard to read, which I'll be happy to share with you. If you email me, I can share you the Word documents. But these are basically step-by-step appendices for how to secure the airway, for instance. And this involves the assistance of a respiratory therapist. I will not go through the individual steps, but These were put together in conjunction with our lead respiratory therapist. And so what it does is enables that if you having a knowledge deficit no longer is acceptable as a reason to not hold, because we are providing education, we have clinical resources in writing and neuro NICU staff as well as respiratory therapists there to assist with holding. The next appendix is Appendix B, is securing tubes and lines. And I apologize for the small font, but these are individual instructions for how to secure PIC, Broviac, PIV, peripheral art line, followed by umbilical lines, followed by chest tubes, followed by OG and replogals. So again, happy to share those documents with you outside of this presentation. And lastly, our Appendix C is considerations during the maintenance phase of therapeutic hypothermia, and step by step of the equipment that is needed for holding. Important to have a pillow and a comfortable chair for the parents to hold in, and then step by step instructions for how to transfer the baby from the bed to the parent. This is a video that one of our nurses helped me put together, which demonstrates the transfer technique. And as you could see in the video, this was a baby that would be on video EG that was laying on a cooling blanket and transferred from the bed onto a pillow, on the pillow to the mother. So this brings me to the study that I have been working on for the past few years. And we think in the neuro NICU that it's important to facilitate holding during cooling. And what we've done is analyze the vital signs before, during, and after holding events, and administered a parent survey about the holding experience. And by obtaining data from the study, we can best demonstrate the safety and feasibility of this practice. So again, here's the holding algorithm, and these are photos that were taken of parents that consented to my study and allowed me to photograph them. This photograph here on the left, you can see we're using the Blanketrol cooling device. Behind the mom is near-infrared spectroscopy, and our Moberg device, which was pulling the vital sign data from the Philips monitor. And then mom has a pillow with the cooling blanket on top of it. The baby's on video EG. And you can see that it's a little crowded, but she looks comfortable, and we were able to safely do this. This next photo to the right was taken more recently. We transitioned from using the Blanketrol device, which is quite cumbersome, to the critical device where it's a blanket that wraps around the baby. And this dad was holding the baby also on video EG. This baby had umbilical lines. And I just love that his hands are touching the baby's feet, and he just looks so peaceful there despite this traumatic time for the family. Going over some of the demographic data, as I mentioned, we initially wanted to our goal was to collect data on 50 patients, but given the number of babies that were born at our outside hospitals and babies that were born by C-section, it was taking a very long time to enroll 50 patients. So what we opted to do was try and get 50 holding events. And we were able to recruit 24 patients, 54% were female. And the infants ranged from 36.7 weeks gestation to 41.43 weeks gestation, with an average gestational age of 39.02 weeks. The average birth weight of these infants was 3,310 grams. The birth weights ranged from 2,580 to 4,678 grams. 29% of our babies that were held during cooling were inborn patients. So you can see that the remainder were brought in from other hospitals. 42% of these patients were born by cesarean section, and it's our standard practice that these moms are hospitalized for 4 days if they deliver babies by cesarean section. I included the APGAR scores here to get a sense of what the babies looked like in the delivery room and how they qualified for cooling. The average 1-minute APGAR score was 2.5, but for the patients that were cooled, the range of 1-minute APGAR scores were 0 to 7. For the 5-minute APGAR scores, the range was 1 to 8, and our average 5-minute APGAR score was about 5. And 10-minute APGAR score was 6.5 and had a range of 2 to 8. The categories for the SARNAT exam, which is the neonatal encephalopathy exam that we use to determine eligibility for cooling, I tracked the number of scores that were mild versus moderate versus severe. And there are 6 categories. Each patient has 6 scores, one in each category. So to better explain this data, the number of categories in the mild area were about 1.5. So most of the babies fell into the moderate encephalopathy category because they had an average of 3.88 or 4 scores in the moderate category. And as far as severe SARNAT exam, it ranged from 0 to 2, but our overall average was 0.58. So again, just to focus that the majority of the babies that were held had moderate encephalopathy. And the ethnicity breakdown for these babies was varied. 29% were Asian, 25% were Caucasian, 25% Hispanic, 13% Black. 2 were identified as multiracial, meaning greater than 2 races, and 4 were unknown. Again, you can see this picture of this mom holding her baby during cooling. So this is the number crunching I've done over the past few weeks. I was able to capture 40 holding events of the 24 patients. And we'll just go through the pertinent data, beginning with respiratory support. 67.5% or 27 holding events occurred with babies on room air, like in this photo. 7.5% were on CPAP, and 20% were on conventional ventilation. 5% were unknown because it was not charted what respiratory support was during the holding time. As far as IV access goes, it is our standard to try and place umbilical lines on these infants because, as you may be aware, once babies get cold, getting peripheral IV access can be quite a challenge. So we generally do place at least one umbilical line upon admission. So almost 58% of our babies had a single umbilical line, either a UAC or a UVC. And 35% had 2 umbilical lines, a UVC and a UAC, or a UVC and a peripheral art line. There were 2 holding events with just a PICC line and 1 with the baby that just had a peripheral IV. As far as sedation goes, it is our standard practice based on a pharmacokinetic study we did with morphine and infants who are being cooled to give a loading dose of morphine of 0.05 mg per kg at the beginning of cooling, and then we infuse morphine continuously at 0.01 milligram per kilogram per hour for the first 12 hours of cooling, and then we wean the dose by 50% and give 0.005 mg per kg per hour during the duration of cooling, and we turn off morphine drip during rewarming. So what I looked at was to see whether infants that were on the morphine drip of 0.005 mg per kg per hour, did they require a bolus before holding? And 7.5% did require a bolus before holding. One of the 3 infants wasn't on a sedation drip. There was 1 infant that did receive a morphine bolus during holding, so that was 2.5%. But 80% of our patients did not require additional morphine for holding, and 10% required a dose greater than 0.005 mg per kg per hour. I just wanted to point out that none of our patients were on inotropes. None of these patients had chest tubes. And most importantly, none of these patients had any untoward events during holding. I looked at the vital signs related to holding. These included core temperature, heart rate, pulse oximetry, and cerebral saturation. I looked at the vital signs 1 hour before holding, during holding, and for 1 hour after holding. And the average time these infants were held was 82 minutes. We asked parents to commit to holding for a minimum of 60 minutes, but as you can see, our range of holding times was 28 minutes to 220 minutes. So quite a bit of variability, but in average, just over an hour, almost an hour and a half holding time for this study. The core temperature, you can see, was very stable. 1 hour before holding, the average was 33.5 with a standard deviation of 0.14 degrees. During holding was also 33.51 with a standard deviation of 0.18. And after holding, a temperature was 33.4 with a standard deviation of 0.16. So this demonstrates that the temperature was not significantly affected by holding. Heart rate also, the 1 hour before holding was just over 100. It stayed stable during holding and increased just a little bit, a couple of heartbeats per minute to 105.56 1 hour after holding. So again, not a significant change in heart rate. With pulse oximeter, we found the same, that the 1 hour before holding, the saturations were just about 94%, and they 93 to 94% 1 hour before holding, during holding, and after holding. And finally, we looked at cerebral saturation and once again found the same, that the cerebral saturations were 82 to 83% 1 hour before holding, during holding, and after holding. So I found this information to be quite compelling, that it is safe to hold during cooling. Now on to the fun stuff. The parent survey that we administered to the family, the mother and fathers who held their babies after their holding events. There were, as I said, there were 40 holding events and 25 parent surveys. So this is what the parents responded to. The statement, "I believe holding will help with the growth and development of my baby's brain." 76% strongly agreed with this statement, and the other 24% agreed with it. So nobody disagreed or at all with this statement. So quite compelling that the parents believe that holding is impactful. If deemed medically safe by the NICU staff, how important is it for you to hold your baby at least once per day or per visit? An overwhelming 88% said it was very important for them to hold their babies. And the remaining 12% said it was somewhat important. No family members felt neutral or that about this question or that it wasn't important. It is clearly something that is important. And I think you can look at this mother's face of what her demeanor was related to holding her baby. If you had a chance to hold your baby, which all these parents did, how do you think this experience affected you? 86% said it significantly improved my emotional and or physical well-being. That just was awesome to me, that this project could have that, this holding could have that much of an impact. And 14% said it seemed to help somewhat. Nobody felt that it made no difference or had a negative impact. If you had a chance to hold your baby, how do you think the experience affected your baby? 50% of the parents said it had a positive impact on their baby, and 50% had a significant impact, a significant positive impact. The other 50% said it had some positive impact. No one said that there was no effect or that it had a negative effect. We also asked what was the biggest barrier to holding? And overwhelmingly, the parents identified the cooling blanket and the medical equipment as being a barrier to holding, keeping in mind that part of this, the holding blankets that we used different types, and I don't have the data whether the perception changed after we switched to the critical blanket, but I would like to look into that further. It also said there wasn't enough room, 19%, but another 19% said there were no barriers to holding. About 11% identified anxiety adversely affecting their baby's care by holding. And other families find their baby's medical problems as being a barrier. Then this was an open-ended question for parents to just give us some anonymous input related to how we could improve our holding process. So these were taken from the survey. The parents said, having less wires and tubes and cables around the baby. For practical purposes, we're not able to do that at this juncture, but I'm hopeful that someday we're going to have monitoring on our babies that is going to be wireless. So we'll look forward to that in the future. Another parent said having a playbook to transfer baby. It felt like each nurse did it differently and they were making it up on the go. We do have a playbook, we have guidelines, but that was an interesting perception that the parent had that we need to look at, having a standardized way of transferring the baby and having that the parents feel that it's a standard way, and allowing, this is another parent input, said allowing holding more than once per day. Found this very interesting because we don't have a policy that the parents can hold only once per day. So I don't know why the parent had that perception, but it was an interesting perception to note. Having the nurse initiate by asking if I want to hold my baby. Wow, that's just incredible. That's something so simple we could do, but maybe we just don't think about, like just asking the family, would you like to hold your baby today? Instead of asking for the family to ask to hold their baby. Some families identified having more privacy, and also the final input was having a leader who's directing specific tasks and not doing anything else in order to coordinate all team members. I'll admit we do try in the neuro NICU to be that leader, but we're not in the unit 24/7 when the infants are being held. That's just an area that we can improve upon. And lastly, I wanted to go over some individual quotations from family members about how holding their baby affected them. We didn't realize we'd be able to hold our baby during cooling, and it turned out to be the best part of our day. So grateful for the chance. It was wonderful to feel close to him during a traumatic time. Another parent said, I produced a lot of milk. Whereas another parent said, it made me feel comfortable and connected to my baby. Profound bonding. One father noted, this is the first time I have cried. I think holding your baby is so vitally important to both the baby and the parents. If the baby can relax and feel supported and confident, I believe she can heal faster. Also, the emotional bonding is so important for health and long-term trajectory. It made me feel comfortable and connected to my baby. I really loved holding my baby because my milk production has increased. And it lifted my spirits and let me know my baby is okay. It allowed her to smell my scent as well as her dad's scent, and we were able to talk to her. Wow, I was really moved by the input that the families shared with me. I hope that it's impacted your perception of holding. And I'd like to just finally thank my neuro NICU team, in particular, Dr. Valerie Chalk, who has been instrumental in my data crunching and guiding me along the way during this study. Rachel Small, who is a nurse practitioner in our neuro NICU, as well as Alara Popovich and Shannon Tinkler, who's a clinical nurse specialist, and Monica Sinha, who is our neuro NICU nurse educator. These people helped me recruit patients, enroll patients, and collect data, and I couldn't have done all this work without them. I'd like to open the floor now to take some questions.
Thank you, Celia, so much. That was really amazing. And it was really great to see the data all come together. There have been a couple little comments and people are just saying, thank you. I love seeing the words of the parents, the impact. People are just congratulating you. Great work. There was a really nice, we'll call it an Ann Shields hack from San Jose, who said that what she does for parents during holding is that she'll actually use the giraffe mattress and just lift up that and transfers instead of adding in a second mattress. So I thought that was a nice way to get around maybe some of the jostling of tubing and also use that as the pillow because it is soft. So people are enjoying that tip.
That's a great idea.
Does anybody want to be unmuted and have a question? Just raise your hand and I can unmute you. I'll keep an eye on the participants list. And what do you guys think about this holding during cooling? Are you doing it? Most people always tell me they're not doing it. They want to do it. Does some of this evidence from Celia's observation study, does it give you some confidence that you didn't have before? Does it make you want to do it? So Ernestina's saying, I'm guilty. I'd like a playbook. I feel like I'm also winging it. Yeah. I think sometimes better to wing it and do it than not do it. But yes, we can always be more organized. So good to see so many different people from around the world. People are just saying, congratulations, Celia. Great lecture, great work. So really good. I had a question about the demographics. Would you mind sliding back to that slide really quick? Sure. And I know as you're diving deeper into the analysis and we're waiting for some other questions to come through, I had a question about that to see if you had plans to look at it or have already looked at it. Just lots of just thank yous and great work. Awesome. Samantha's saying we are holding in her unit, but in her opinion, not enough. Probably not. Most of us are probably guilty of that, but congratulations for doing it at all. That's a big step, and excited to share the takeaways and improve confidence. And you can see, using Celia's research as a guide for your hospital, you could do a quality improvement project in your hospital too. If you already believe in the value of it, believe it's safe, or can get consensus that it's safe, or use Celia's and the Stanford's holding algorithm. I hadn't really seen it presented that way before. And I thought your algorithm was also really helpful for all babies. So I thought that was great. So what I thought was interesting was you were mentioning that for the babies who were offered holding, how much they were scoring out in the moderate area. And I wondered if maybe in the same period, if you maybe control matched them with babies who didn't get held to see if were the babies just not eligible. So how many fell into the defer or the not stable enough category during the same period? I wondered if you thought about looking at that.
I do collect data as part of all babies that are cooled. I haven't looked at them individually. I know that these babies all qualified for cooling. I have not gone back over and compared them with, because it was done over since 2018 up to 2021. I guess I could. Yeah, I could say percentage wise, I do it on an annual basis, but I could pull that data together. Yeah, because there were babies that were eligible that weren't held.
Yeah,
for sure.
I wondered, were the other babies just so much more severe? Is that why they weren't included in this, or were they, anyways, I just thought about that.
I think that some of the variables were that the moms were at different hospitals. That was what I was trying to point out, was that only 29% of the babies that were held were actually born at our hospital. The remaining 71% were born somewhere else, and getting the mothers transported, or if they were born by vaginal delivery, the moms could get discharged in time to hold their babies. But 42% of them were born by C-section, so the moms were hospitalized somewhere else. So in my data collection, of all babies that are cooled, they would fall into being eligible but weren't held because the parents weren't there. We also had babies, for instance, that the parents were COVID positive and they weren't able to come and visit. So the babies could be held, but we couldn't because of COVID.
Yeah. This is so good. So there's so many questions. Jess Matei saying, love this, Celia. And then she said, did you see any evidence of the cooling machines that you were using adjusting to compensate to keep the baby in that target temp? And were the temperatures consistent throughout? Did you have any drifting? So do you want to answer? I know you have that data, but I don't know if you've.
No, so we did not see any drift. At all. No, not at all. These numbers were rock solid.
And then I know you could go back probably because you were using the multimodal device to look at the actual blanket set point temp. Do you recall, or have you looked at whether or not the blanket changed during that time to keep the baby?
I did not track that information, but that is possible. But the blanket is designed to maintain the baby's temperature, so that is certainly a possibility. But it did not impact the baby's core temperature.
Yeah, it might be interesting too, because let's say like now you have the Criticool and before you had the Blanketrol, right? And so when the babies are laying in the bed, they probably aren't getting as much surface contact when they're being held. So it may be interesting, but not mean anything if you saw that the temp of the blanket went down or up, because there could be differences in the amount of surface area.
Yeah.
That was being held. But it's interesting data. Actually, there was a poster at PAS where they were looking at the temperature set point of the blanket as a surrogate for severity of injuries and trying to look at whether or not the blanket was having to work harder for babies who were more severe. More to come on that. I think that's a really interesting question.
I know anecdotally that babies with severe HIE, their temperatures plummet, like when they get passively cooled, and the machines do have to work harder to keep the babies warm. It's not a matter of cooling them, it's warming them to 33.5 degrees, because that is a challenge.
Yeah. Did any of the parents mention that that they felt cold while holding?
No, there's actually, I think with the pillow on their lap, and then actually if you put your hands on the blanket when it's quote unquote cooling, it actually feels warm, because it's 33, it's keeping a baby's temperature at 33.5 degrees. So it's 92 degrees. So it does feel like there's warmth more than coolness coming from the blanket.
That's me too. I think that we think cooling blanket because we're giving hypothermia as a treatment, but the blanket itself, except in those situations, like you mentioned, when maybe I think we think about the induction phase when the temperature of the blanket does feel cooler. And once they're in maintenance, I agree with you. It does. I think it's more our own perception that it would. Stina from Sweden has a great question, which is, have you measured, or maybe in the future would consider measuring, maybe holding and skin to skin time for babies that got holding during cooling, and then comparing that to the post rewarming phase? Are they more confident and therefore doing more of that? Or do you go from a 0 to 100 at that point?
I'm sorry, you said skin to skin during?
Yeah, so just have we measured after rewarming, the incidence of holding or skin to skin? Does providing holding during cooling influence that?
Oh, wow. That is a fascinating question. I haven't thought about that. That is something we could definitely look at.
Stina, we'll leave it to you. We know you do so much developmental care and family-centered care. So Elena is asking, what implementation process did you use to get nurses and staff on the same page?
Yeah, thank you for asking that. We have a nurse educator that has been instrumental. Shannon Tinkler and Monica Sinha have been instrumental in educating the nurses and doing skills labs, practicing moving patients from the bed to the parents. Jess Matai, who is our developmental specialist, put posters around the NICU to educate that holding is good for your baby's brain. And we just really promoted holding. We talk about it in rounds. We educate the nurses in their skills labs, and just making it part of everyday care. And can this baby be held today? What are the barriers to holding? Making it part of our rounds discussion is helpful.
That's great. I'm just seeing lots more. So 2 questions have popped up during the chat here. One of them is trophic feedings during cooling. And I'm really excited that we are going to actually have a presentation about this. And I see that our guest faculty is here, as well as a question about mild HIE, which I also see our guest faculty are with us today. We are going to have some presentations from Dr. Shalak, as well as from Dr. Albaraki coming up in May and June, that will dive a little deeper into those continued controversies as well. There was a question, but I think you addressed it, about just enrollment in your study during COVID. And if you noticed how COVID has impacted that.
Yeah, actually the slide that we're on, the picture on the left, the woman wearing the mask, that was the beginning of COVID. COVID has impacted all levels of care. So yes, invariably, yes, we've had some patients that were not able to be held because of COVID.
So there was a question about whether or not you needed consent, and maybe talk about what you're doing now. Have you transitioned this to standard of care? Are you still consenting families so that you collect all of the other data and get their survey input? Where are you now with all of that?
So I've closed enrollment. Yes, this was an IRB approved study. And so there was a written consent form that the parents signed. We had a consent form in Spanish and in English. And I'm not collecting data anymore. The medical device, the Moberg device that I use to collect the data, doesn't communicate with our Philips monitors anymore. So I don't have a way to pull all of that data together simultaneously. And after meeting with Dr. Chalk, she really has helped me tremendously with this study. We decided that 40 holding events is significant in and of itself, and that it's probably at this point more important to get the information out there than to try and just get to 50 holding events, just to have a round number, if you will. So we feel like 40 holding events using multiple cooling devices with data that's just very supportive of holding was more important, just to get the information out there.
Yeah, that's great. So there is a question about, and maybe it's a twofold question. One is, when you don't have an algorithm like you've created, there can be some nurses and physicians who will allow holding, and there are some that won't. How can we standardize this? And does it still happen even with the algorithm?
It happens less often with the algorithm, but it does still happen. And that's actually, I meant to bring that up, that if you have variability in practice where one nurse says, oh yeah, we can do this, we can make this happen. And then the next shift, the nurse is, oh no, your baby's too unstable. You create trust issues with the family because the family doesn't understand what, if the baby is clinically the same, why were they able to hold at this one time and then not able to hold another time? That was an impetus to set up the algorithm to standardize the way that we approach holding, so that it's not provider specific, it's baby specific. Is the baby stable enough for being held? And if so, what can we do to make this happen? And if it means call the respiratory therapist to the bedside, call myself to the bedside, I'll stop whatever I'm doing in the neuro NICU to come over and facilitate holding, because I believe that it's very important and I will make it a priority, and my colleagues do as well. So the algorithm, when we designed it, it was really a tool to make it with the goal of it becoming obsolete, so that people were processing, is this baby stable enough to be held? Yes, let's get the baby held. It was designed to address the discrepancy between providers.
No, I love that. It's great. Oh my gosh, there's so many really great comments in here. Loving this language, baby specific, not provider specific. So now in regular practice, does the provider give an order for holding, or with the algorithm, do the nurses follow that? And how does that coordination between your rounding and is there like a green light, a green, yellow, red light? How do you communicate this? How do you, between the disciplines, communicate who's eligible and who's not? And then if they are eligible, does it require an order?
Yeah, it's supposed to happen daily on rounds, and it's not a written order. It's just supposed to be a verbal communication, because nurses don't need medical orders to facilitate holding. That has never existed in our unit. That's never been a barrier to holding, that you needed a medical order for it. It's nursing discretion. And I think we could do a better job of ensuring that the discussion happens for every baby during rounds. But I think we've made improvement, but I think that we could still do a better job in ensuring that if we have the discussion every day, if it's a checkbox on our dashboard of things and we check off a lot of things. And each patient, before we move to the next patient on rounds, you check your respiratory alarms and apnea alarms. And this should just be part of our practice. Is this baby eligible for holding?
Absolutely. I totally agree. So there is one final question, which may be a very big one that I'm not even sure we'll have time to really go into. And so Stina is also bringing up that we have a lot of evidence for skin to skin. And do we have evidence that just holding without any bodily contact is a good idea and improves outcome? And if you know of any references, would you share them, or what do you think about that? comment?
I do not know of any references that show outcome. I don't think there have been that many studies that have looked at holding. What I found most moving was the parents' reaction to holding and focusing on um, neuroprotective care, and that the parents' holding experience profoundly affects the parents, and the parents believe that it affects the baby. And that, to me, is compelling enough that the parents are obviously going through trauma. Nobody is expecting their baby to get cooled. When they're going in to deliver their baby, they're all in a state of shock. And what we can do to ease their stress, I believe, is going to be beneficial to the baby. So does it affect long-term neurodevelopmental outcomes? I don't have the answer to that. But I've spoken with the families, and their individual subjective input was really compelling for me.
Absolutely. Absolutely. And I do think there are probably some anecdotal, and Stina, you probably even know better than me to share the references about just parents who aren't able to hold. And I know there have been at least qualitative conversations about the trauma of not being able to hold, the distress that causes. So I think what I love is that while we're talking about this, we're looking at this slide that shows the vital signs, right? And that I think this is the worry, that holding will be stressful to the baby, that holding will interrupt our therapy. We won't be able to deliver the hypothermia that we're intending. And I think that this data really does show that. And it would be, I think this is much like when we have gone through the eras of holding small babies skin to skin. What's the evidence? What's the evidence to keep babies in their bed separated from their parents? We have less evidence probably to separate families, but we do it every day and put these barriers between us, the parents, and the babies. I think we probably need to flip it. What makes it unsafe? And I think your evidence shows that it is, from a physiologic point, it's safe. And someone's making the mention of just looking at their vitals afterwards, which you did, and you showed that they were stable. And just like we've had to do with skin to skin, do babies have Brady's and DSATs or any other needs post? But I think in this situation, the therapy is the temperature. You've demonstrated that the temperature doesn't drift. This 0.1 degree difference, my theory on that is that it's probably because they had better contact and that they're just recalibrating. Once they're back in bed, they're less contained, which means it's probably more stressful on them. So I think it probably demonstrates that holding them is, number one, super safe, and number two, doesn't change that. And I think it's a call to action for all of us, right? If you have questions, just like Celia did and needed to prove it to her team, she studied it. And it's not an easy feat. We all want to congratulate you, Celia, for doing this, and also just for sticking with it through your own personal health, through the pandemic, and all of that. Doing research is not easy, but it's so important to inform us all and to inform the community, to inspire others. I think just congrats.
Oh, I wanted to mention one other thing about the algorithm. Another reason I would encourage folks to have an algorithm is, if something does go wrong, if a patient extubates when you're endorsing holding and you don't have a standardized way of securing your endotracheal tube, you are going to have massive numbers of people saying, we can't do a holding, it's not safe. But if you establish safe steps for securing the ET tube, securing the lines, having all these safe, and the tubing from the cooling blanket, step-by-step ways to make sure that everything is done properly and the baby is moved safely, that is why I attribute we didn't have any untoward events, because we went through all these steps to make sure that those things didn't happen. And if you don't have a holding algorithm with steps to follow, it's just going to take one episode of somebody getting extubated, some line coming out, and then your whole unit's going to just say, nope, we're not doing it, it's not safe.
So someone is asking, have you created a family brochure about this? That's an excellent idea. And did you track extubation rates? You just mentioned there were no untoward events, but
20% of our babies were held that were intubated. Mm-hmm. None of them were extubated during holding. None of them had.
Yeah. And there's a little conversation in the chat going around about offering skin contact during cooling. I don't think that Celia is in any way endorsing that, nor do I think there's been anybody who has studied that. I guess what I would say is baby step forward and let's study it as we go. The first was for these very stable babies, why are they laying in the bed? Like they can get their cooling therapy and lay in mom's lap. I think to take that to the next level and to say, is there microbiome benefit? Are there other immunologic or stress marker benefits to offering maybe the mom's breast exposure or laying on the baby? I don't think there's evidence, nor I have heard anyone advocating for that. So I think it's more about just reducing separation. It's about reducing the trauma of it by offering and normalizing, which is what Dr. Craig's data would show, normalizing behaviors. Holding your baby is a normal activity. I don't know, Celia, if you wanted to comment to this idea about opening up the critical blanket and allowing skin to skin contact.
Yeah, I don't know enough about that. Is outside of what I would feel comfortable recommending, because the way that we've maintained the stable temperatures is by maintaining the baby in contact with the blanket. I would pause before recommending that.
Yeah. And I think offering scent cloths and doing some of the other sensory experiences with that, I think your point, as Shannon just said, is excellent. And not to say that the blanket couldn't work harder to maintain that, but I would say to what end and to what benefit, we don't know. And maybe that's something one of you will investigate someday. But I think, yeah, I would say we're trying to just transfer what we were doing in the bed to the parent's lap, I think is the best way to say that. We made sure the baby had full blanket contact. So Shannon was the neuro NICU coordinator at that time. She was saying we didn't open the wrap to do skin to skin. We just wanted to make sure that they had full contact and that they kept the baby stable. And baby stay on the pillow mostly to insulate the baby from holding the kind of rough wrap. Great idea about the family brochure. You guys are awesome. There's still 100 of you here. Oh, somebody asked about the frequency, Celia, and maybe in your final paper, you'll add this in for each of the parent-child dyad. How many holding events did they have? Or did some families have multiple? Did some families only have one?
Yeah, I have that data. Okay. Some families only have one. I think the most holding events, it was either 4 or 5 with one patient. Yeah, I definitely have that information.
Yeah, I think people are curious and key. And all of the holding events happened after initiation and kind of core temp was achieved.
They all happened during the maintenance phase of cooling.
Yeah. So depending maybe when that first one was able to happen, you only have so many hours to squeeze them all in. Great. Again, Celia. Oh, I had one more question. I know you all have to indulge me, and hopefully, Celia, you have 2 more seconds. If you go back to the demographics, I was just on a call yesterday talking about skin to skin and the disparity that exists between races in the NICU of skin to skin holding. And I noticed in your study, you also had less African American holding experiences. And I wondered if that translated to, again, going back to looking at all eligible babies during that time, were less African American families offered cooling, or not offered cooling, but offered holding during cooling, to look to see if that disparity in skin to skin might also translate to disparities in offering holding to babies. So just something to keep in mind. I know as we're focusing more on these health determinants of health and equity across the races, we see this in skin to skin. And I just thought it was interesting that only 13% of the babies were Black, but also maybe only 13% of our population. And so maybe it's 100% of all Black babies were offered, and only, I don't know the number, but I think
I was going to say.
Yeah. So I think it'd be interesting to look at how did this mix of babies who were offered cooling and who also opted to participate, how does that fall out, and whether or not we have opportunity to make sure we focus in on those opportunities. Anyways, just a comment that I noticed just because I was on this call yesterday and someone brought that up. Thank you to all of you for giving all of these amazing just comments and questions. And again, thank you a huge number of times to you, Celia, for being with us. It's been really amazing and
my pleasure.
Really great. People are just saying thank you, and thank you
all for giving me time to share.
Your inbox is going to be full. I hope you're aware of that.
Okay. I'm not at work today, so I will not be checking my work email, but I will get if you email me at my Stanford address, I will get it, and I promise I'll reply.
Oh, that is so great. Well, again, I just want to say thank you all for being part of our series this month. I know all of you are very keen, and people are encouraging you, Celia, to publish this. They all want you to publish it.
I'm working on it. It's coming.
Awesome. Don't miss our Facebook group. I hope that you are there and participating and asking questions. And don't forget to pick up nursing CEs if you want them. Hopefully you're all enjoying this and you can opt in for some of these other opportunities that we have. So anyways, with that, I'll wrap up the day. Thank you again, Celia, for taking so much time out. I know it's been a crazy week, and we're so grateful to have you here. And thanks to all of you for being a part of our series. And we look forward to continuing the conversation in the future.
Thank you, everyone.
Bye, everybody.
If you've enjoyed this presentation, I hope that you will subscribe to our YouTube channel, hit the notification button so that you're notified of when we're going live again, and follow us all month long, HIE Awareness Month, so that you can be up to date with all the current practices and best advice that we can give you from it. Don't forget, I'd love to see you guys communicate down in the chat below. Just go ahead and chat. Are you guys offering holding during cooling? And what are some of the barriers in your unit? Let's have the discussion down in the chat.